Hello, testing. Perfect. Okay. Hi, good evening, everyone. I'm going to go ahead and kick us off because it's a little past 5:30 and we have a very packed agenda for this evening session here. So thank you for joining us this evening. We have a great session, poster spotlight session focused on prevention. And we have 8 poster presentations, and with the new format this year, we have the pleasure of hearing directly from the poster presenters. They each have 4 minutes to present 4 slides, so this is going to be rapid fire. And then we have 2 excellent discussants who will be sharing their views and putting all of the data together here. We'll start with Dr. Pam Goodwin as our first discussant, followed by Dr. Seema Khan as our second discussant, and we'll try to wrap this all up in an hour. So everybody buckle up, and here we go. So I'm going to introduce the first speaker. This is Dr. Serrano from the European Institute of Oncology in Milan, who will be giving us a short presentation on exemestane and breast cancer prevention. Dr. Serrano.
So, thank you very much for the invitation. I'm pleased to present this new analysis from the presurgical study that we have done. I have no disclosure to make. This one. Okay. Big green button. Okay. Okay, so in the presurgical study, we have shown that 3 times exemestane 3 times a week is not inferior to the daily dose in reducing serum estradiol level. Here, we measure the drugs and the sex hormones in breast tissue to understand how low we can go. The measurement was done in a frozen sample taken at the surgery, and we measure exemestane, 17-hydroxyexemestane, and 4 different sex hormones. All the analysis was done by MS analysis. The tissue exemestane and 17-hydroxyexemestane level were detectable only with the daily dose, whereas the 3 times a week and the once a week schedule, they were below the limit of detection. Drug distribution is not evenly distributed, and we saw much higher concentration in non-malignant tissue versus the cancer tissue. Estradiol concentration in malignant tissue exhibited a dose-response trend, but the difference between the daily dose and the 3 times a week were only borderline significant. Estradiol concentration in non-malignant tissue were below limit of detection nearly in all participants across the groups. In conclusion, exemestane has a short half-life, and probably due to this reason was detectable only on the daily dose. And the different distribution between the non-malignant and the cancer tissues is probably due to its lipophilic nature. In malignant tissue, the estradiol show a trend in dose-response trend, and the daily dose with versus the 3 times a week show only a difference, a borderline difference with the P of 0.46. Irrespective of schedule, in non-malignant tissue, estradiol level were very low in all arms, potentially due to its permanent inactivation of the enzyme. These findings have shown as to be considered exploratory, but they support the rationale to further study alternative schedule and low-dose exemestane in breast cancer prevention, although toxicity profile needs to be explored. Thank you.
Thank you very much. I wasn't kidding when I said rapid fire, so we really get to hit the key conclusion points here. So next, I would like to invite Dr. Schrup to the podium from Mayo Clinic in Minnesota, and she'll be presenting her study on benign breast disease and microcalcifications in percutaneous biopsies with relationship to breast cancer risk. Dr. Schrup.
I'm not quite a doctor yet. I'm a medical student at Mayo Clinic, but thank you. I am excited to be here today to present on benign breast disease and microcalcifications. Here's the financial support for my project. The next slide. Let's see, green button. And I have no relevant financial disclosures. So studies have suggested that microcalcifications or calcs in benign breast disease impact breast cancer risk. However, the frequency of calcs and breast cancer risk associated with calcs during the percutaneous biopsy era have not been clearly established. Accordingly, we assess the association of calcs with specific benign breast disease lesions and breast cancer risk in a large contemporaneous benign breast disease cohort, including detailed pathology review. Histology of all biopsies was reviewed, and microscopic findings were recorded for a cohort of 4,819 patients with percutaneously diagnosed benign breast disease from 2002 to 2013, with follow-up through 2022 at our institution. A natural language processing algorithm was developed and utilized to identify the presence of calcifications on clinical pathology reports. Age-adjusted Cox proportional hazard regression for specific BBD lesions stratified by the presence or absence of calcs were developed, with estimation of an interaction term to test for significant differences in risks. Standardized incidence ratios estimated risks for calc-positive and calc-negative benign breast disease lesions versus matched strata from the Iowa SEER population-based breast cancer incidence rates. And further subgroup analyses were performed for cases of DCIS only, breast cancer only, BBD biopsies in the digitized versus non-digitized mammography eras, and the age of at benign breast biopsy. Our findings are that the mean follow-up was 11.3 years for BBD patients who remained cancer-free in follow-up compared to 7.4 for patients who did not remain cancer-free. The natural language processing algorithm achieved a high specificity and sensitivity in identifying calcs compared to manual abstraction of pathology reports. There were significantly more calcs in biopsies preceding cancer than those that did not precede cancer. Overall, risks of breast cancer among women with BBD calc-positive biopsies did not differ significantly from those women with calc-negative benign breast disease, with the hazard ratio of 1.13, and SIRs were similar between the two groups as well. Hazard ratios were similar for specific calc-positive and calc-negative BBD lesions, with progressively increasing risk for non-proliferative disease and then proliferative disease without atypia, and finally the highest risk associated with atypical hyperplasia as expected. The interaction term, however, indicated a non-significant relationship between calcs and risk of resultant cancer after benign breast disease. Further stratification by subtype and analysis with SIR did not reveal significant difference between calc-negative and calc-positive risk. Subgroup analysis for cases of DCIS only, breast cancer only, BBD biopsies from the digitized versus non-digitized mammography eras, breaking at 2008, and age breaking at 50, did not reveal any significant associations in subgroup analysis for calcs between when analyzing for breast cancer risk. So in conclusion, in this large contemporaneous cohort, we found that calcs sampled percutaneously and identified pathologically in benign breast disease were not associated with increased risk of breast cancer. Thank you.
Okay. Very good. I have questions for both speakers, but that reminded myself that please write your questions down and save them. We'll wait till the end of the session so we can make sure we get through everyone, and then we'll invite your questions. So next I'd like to invite Dr. Joanne Mortimer from City of Hope in California to present her study, Randomized Trials of Estrogen-Alone and Breast Cancer Incidence, a Meta-Analysis. Thank you.
Thank you, Neil. On behalf of my colleagues, especially Rowan Schlabowski, who's unable to be here, thank you for allowing me to present this data. Here are my conflicts. The increased incidence of breast cancer in women taking estrogen alone has been a controversial topic, as observational trials have conflicting results to the Women's Health Initiative trial. For example, the collaborative group meta-analysis of 24 studies in over 100,000 women identified an increased risk of breast cancer with estrogen alone of 43%. Similarly, in the Million Women study, 661 breast cancer deaths were identified, and this was consistent with a 35% increased mortality in women on estrogen alone. The Women's Health Initiative randomized trial of estrogen alone versus placebo, however, reported 534 breast cancer patients with estrogen alone, and this represented a decrease in incidence of breast cancer compared to placebo of 22%, and overall decreased breast cancer mortality of 40%. Therefore, we tried to identify other randomized trials of estrogen alone to increase the sample size in a meta-analysis. 9 additional studies were identified, included an additional 3,500 patients. The largest component of this study, however, is the Women's Health Initiative trial. And just to remind you, the eligibility were postmenopausal women with a prior hysterectomy who did not have breast cancer and had a negative screening mammogram at the time of enrollment. Participants received conjugated equine estrogen. On the right, you see the most recent summary of the results of the WHI, looking at the stratified score statistics according to patients in yellow who received estrogen and progesterone, and in the blue, the single-agent estradiol, conjugated estrogen. The solid line indicates the incidence of breast cancer, which of course is increased in patients who were on estrogen and progesterone, and the dark blue line below shows a decreased incidence of breast cancer, which was statistically significant at 5 years and has continued to be statistically significant. Participants were on conjugated estrogen for a total of 72 years median, and the follow-up now is over 20 years. So if we look at the mortality in the small dashed line, on conjugated estrogen alone, the favorable breast cancer mortality finding has incrementally strengthened over the past decades. This slide just summarizes the 10 studies that are included in this meta-analysis. The 9 studies, the 9 smaller studies are included in addition to the Women's Health Initiative trial. Of those 9 studies, 6 did require that you could not have a prior history of breast cancer, and 5 required a baseline mammogram. Within the 10 studies, conjugated equine estrogen was used in 4, estradiol in 5, and 1 study used estrone sulfate. Of the 2,400 patients in the estrogen alone group of these 9 studies, there was an incidence of breast cancer of 1.2% and 2.2% in the 1,500 in the control arm. This slide summarizes those results. So for the 5 trials that evaluated single-agent estradiol as the estrogen alone, the relative risk of developing breast cancer was, I just lost my slide. It's not, okay, was 0.63, a decrease of 37%. The 9 small studies are summarized, and their relative risk of reduction of breast cancer was 35%. The confidence limits are fairly wide. But when you add the very large Women's Health Initiative study, the relative risk of breast cancer is decreased to 0.77 with very narrow confidence limits. So we would argue that the totality of randomized clinical trial evidence indicates that estrogen alone significantly reduces breast cancer incidence. I want to thank the tens of thousands of people who are involved in the conduct of the Women's Health Initiative trial, which really is arguably one of the most important trials of postmenopausal hormone replacement therapy. Thank you. Oops, I'm moving.
Okay, and our last speaker in the first half of tonight's session is Dr. Lauren Cornell from Mayo Clinic, Florida, who will be presenting her study, Improved Uptake and Adherence to Prevention Medication with the Use of Baby Tamoxifen in High-Risk Patients. Dr. Cornell.
Wonderful. I want to thank the course organizers for the opportunity to present our data. And as a background to our study, we all know that women who are at increased risk for breast cancer may benefit from the use of tamoxifen to help lower their risk, although historical uptake to tamoxifen in the prevention setting has been quite low. So we now have the TM01 trial data that showed us that the use of baby tamoxifen at 5 milligrams a day for 3 years in women with high-risk intraepithelial lesions has similar efficacy to standard dosing of tamoxifen with lower potential for side effects or adverse events. And that's what led us to this trial in evaluating our patients at increased risk for breast cancer, with the primary aims to first evaluate our patient understanding of their breast cancer risk and the role of prevention medication with baby tamoxifen, including benefits, side effects, and risks after consultation with a breast specialist. And second, to assess the uptake, adherence, and tolerability of baby tamoxifen at 1 year in the real-world clinical setting in women at high risk based on risk calculation, based on the presence of DCIS or a high-risk intraepithelial lesion. So we offered participation to women seen at the Mayo Clinic Breast Center in Minnesota or Florida who qualified for prevention medication due to any of those reasons. All women received a standard of care consultation with a breast specialist for discussion of prevention medication rationale, benefits, side effects, and risks. And then patients who were deemed appropriate candidates for baby tamoxifen by their provider were then completed a baseline survey to assess their understanding of risk and the role for prevention medication, as well as a 1-year follow-up survey. So we had 41 patients who were consented for participation at baseline, with 31 patients completing follow-up at 1 year. Of the 31 patients who completed follow-up, 13 qualified based on their risk calculation score, 13 based on the presence of high-risk intraepithelial lesions, and 5 due to the presence of DCIS. At baseline, we saw that 90% of our patients reported good or complete understanding of their breast cancer risk after the consultation, emphasizing the benefit of that consult. And 73% reported that the availability of baby tamoxifen helped in their decision to consider a preventative medication. Of those who completed the 1-year follow-up, 74% reported that they initiated baby tamoxifen after their consult. Those who did initiate were more likely to have DCIS or a high-risk intraepithelial lesion than those who did not take the drug. And 78% of those who initiated the drug were still taking the medication at 1-year follow-up. Patients who continued on the medication at 1 year had a higher estimated breast cancer risk, with an IBIS 10-year risk of 12.7%. Compared to 7.6% in those who had discontinued. And patients with DCIS or high-risk intraepithelial lesions were more likely to continue the medication at 1 year compared to those patients who had qualified based on their calculated risk scores, likely due to the inclusion criteria in the TM01 trial. Of those who discontinued, all listed side effects as the primary reason for discontinuation, referencing hot flashes, night sweats, and fatigue. But again, only 5 patients discontinued during the study period. So in conclusion, we saw that uptake to baby TAM after informed discussion in patients who qualify is high, especially in those patients with high-risk intraepithelial lesions or DCIS. And adherence and tolerability at 1-year follow-up is improved compared to what we would expect with traditional dosing of tamoxifen. It's important to note that the NCCN guidelines and the ASCO clinical practice update now include low-dose tamoxifen as an option for select women. And future randomized controlled trials on dose de-escalation of tamoxifen in high-risk patients based on their risk model assessment still needs to be done. And future studies should also focus on markers to identify candidates best suited for low versus standard dosing of tamoxifen. Thank you.
Great, thank you. I'd like to thank the first half speakers for impressively staying within the 4-minute time limit. Next, I'd like to bring up Dr. Pam Goodwin from the Mount Sinai Hospital, who will put all of this together for us and share her views of the data. Dr. Goodwin.
Thank you, and it's a challenge to put all of this together in just a few minutes. Okay, green, okay. These are my disclosures. I'm going to start with the study of microcalcifications and in benign breast disease. And you've seen this slide already, and this study concluded that the presence of calcifications were not associated with breast cancer risk within each category of benign breast disease. So as the risk histologic risk increased, the percentage of microcalcifications increased, but within each of those categories, there was no association. This is an important study. It's a large study, very well done. And the investigators used contemporary approaches to breast imaging as well as to assessing the pathology. The results here contrast to some extent with a study that was presented in the plenary session this morning, which suggested that in at least some subgroups of women under the age of 60, the presence of microcalcifications in the breast biopsy tissue may be associated with a somewhat increased risk of breast cancer. So I think what is needed here is some additional research to understand the difference between these studies, but more importantly, to look at perhaps a little bit more characterization of the calcifications and of the different subtypes of benign breast disease within each of these broad categories of benign breast disease. But I think this is an important study. I'm now going to turn to the baby TAM study and the study of the less frequent dosing of exemestane. And you've also seen this slide. So the uptake to baby TAM was enhanced in this study after a 1-hour consultation about breast cancer risk and breast cancer prevention. And the adherence and tolerability at 1 year was enhanced with baby TAM. And I think that's an important finding. With the exemestane study, what we saw was that in malignant tissue, so what we saw was the drug was taken up to a larger extent in malignant tissue with the more frequent dosing. But with the three times weekly dosing or the weekly dosing, there was some suppression of estradiol as compared to the daily dosing. And in particular, the 3 weekly dosing appeared to perhaps be of interest for future prevention studies in that it seemed to suppress estradiol to a large extent. So what are my comments here? Well, we've already heard the ASCO guidelines. There are 4 drugs that are approved for cancer prevention. In premenopausal women, it's tamoxifen and potentially baby TAM. In postmenopausal women, tamoxifen, raloxifene, exemestane, and anastrozole. The RCTs show a 50% or greater reduction in risk, and there's been no head-to-head comparisons of the different agents or the durations or doses. The problem is that uptake has been persistently low, and at the level of the population, less than 5% of those offered chemoprevention actually start treatment. So both of these studies underscore potential approaches to enhance uptake and enhance compliance, and I think should be pursued. And I'm just going to skip to the next slide for the interests of time. I want to spend the rest of my time on the Women's Health Initiative study. And you have seen this slide. There's a discrepancy between the observational data and the randomized data when it comes to the impact of estrogen, unopposed, on breast cancer risk. And you've seen this slide. 92% of the events from this meta-analysis came from the Women's Health Initiative. So it's really driven by the Women's Health Initiative. That's the red arrow. You can see with the 2 green arrows, however, that there's a roughly comparable, perhaps even greater effect in the non-Women's Health Initiative trials, low powers, so the confidence intervals include 1. And there didn't seem to be, the use of estradiol seemed to yield results that were similar to the use of conjugated equine estrogens. So what could account for the qualitatively different results in RCTs versus observational studies? Well, I think study design is a critical factor here. There is an increased risk of bias and confounding in observational studies. And observational studies, despite their reduced generalizability, are considered the gold standard for the evaluation of treatment effectiveness. Certainly the hazard ratios that were seen in the observational studies, the modest increase in breast cancer risk, could well be due to bias and confounding. I don't think there's strong evidence that the type of estrogen used in the different studies might have contributed to the discrepancy, or the timing of estrogen after menopause onset. So the Women's Health Initiative has been criticized by some as starting estrogen much later than was started in many of the observational studies. But in fact, the Women's Health Initiative, if anything, shows a stronger effect when it started at a younger age. Sorry, this is not, there we go. So how do I view these results? Well, RCTs are considered the gold standard. The breast cancer outcome was a primary safety outcome, but you've already seen this slide. It's highly unlikely that chance, if the evaluation of a safety outcome rather than the primary efficacy outcome, and the multiplicity of outcomes that were analyzed, it's highly unlikely that chance accounted for this significant result. The p-value, if you look at the right-hand side of this figure, ranged from 0.01 to 0.001, so 1 in 100 to 1 in 1,000 likelihood that the results are due to chance. So that is not a concern for me. The protective effect of the Women's Health Initiative is striking and it's persistent. And again, you've seen this slide. Look at the green lines, and you can see that the effect is seen well before the discontinuation of the drug at an average of 7 years, and it persists with very long follow-up. The women's health results are supported by the other randomized trials, but what concerns me is that we don't have a strong biologic understanding of why giving estrogen should have a similar effect to removing estrogen in terms of breast cancer risk. So do I think clinical practice should change? Well, the Women's Health Initiative findings of a protective effect of CEE are potentially relevant only in a subgroup of women, postmenopausal women who've undergone a hysterectomy. We know that at least 4 agents are effective in reducing breast cancer risk in that population. The point estimates of risk reduction in the Women's Health Initiative suggest that CEE may be less effective than the other chemopreventive agents, a 22% reduction in risk versus a 50% or greater reduction in risk. And apart from a beneficial effect on hot flashes, the toxicity of estrogen in hysterectomized women overlaps that of tamoxifen. So on balance, I feel that a focus on enhancing uptake of the existing agents that are well studied should be a priority. Having said that, I believe that women who receive estrogen alone for indications other than breast cancer prevention, for example, hot flashes, should not be advised that their breast cancer risk will be increased, and in fact may be told that their risk may modestly decrease. So my interpretation of this is very much in keeping with the current ASCO practice guidelines, that we should focus on the agents that are the best studied. That was very fast. I'm happy to answer questions during the discussion. Many points I would have liked to have raised but didn't.
Okay, wonderful. Thank you, Dr. Goodwin, for that very enlightening summary. So I'd like to take some time, just a few minutes, maybe 2 questions. We can open it up to 2 questions from the audience before we move to the second half. So please feel free to come up to the microphones to ask your questions. I'll sort of kick it off. I do have a couple of questions, but I'll start with Dr. Mortimer with a quick question here. Were you able to look at the data from the WHI stratified by body mass index?
No, we did not look at that, no.
Okay, is that data available?
It is available. Whether it's reliable, I think, is another question. But yes, there is data about BMI within the WHI, yes.
Okay, very good. Yeah, that would be perhaps something interesting to take a look at. And as a follow-up question, I know you showed the different types of estrogen that were used across study. Were there any major, dose differences?
Again, that's not available in the data. I mean, they were given. The data on dose in the WHI is not as reliable as whether they're on something or not.
Okay, thank you. I see a question over here at the microphone. Please go ahead. And if you could introduce yourself.
Thank you very much, Dr. Leloge from Paris, France. Thanks for the wonderful talks and discussion. It's for Dr. Cornell on baby time. I was wondering, a very simple question. I was wondering whether you had a specific decision aid for this patient, especially what wording you used, because I think the word baby time is something that seems very harmless, and it potentially has an impact on the decision of the woman to take this pill versus different thing on aromatase inhibitors, etc.?
So to clarify, your question is whether the terminology helped improve uptake. I think it's very possible. I also think, Dr. Goodwin and I were talking before we spoke today, one of the benefits that we have in our current high-risk clinic is time, right? So the patients come to see us and they spend an hour discussing prevention and screening strategies with a breast specialist, and I think that that improves uptake to prevention medications in general. And we've not looked specifically at our data on uptake with other medications. I will say in my clinical experience, it's not as high as it was in this study with the baby TAM. So I do think that might contribute. I think there's a lot of factors that probably contribute.
You do use the term baby TAM?
I do, yeah.
Okay, thank you.
Great, thank you for the question. Let's see, any other questions at the microphone? Over there, please, go ahead.
Hello, Carolyn Baker, breast surgeon from Melbourne, Australia. So we've had two presentations today looking at the risk of benign breast disease and calcification with slightly different outcomes. Neither presentation was clear to me as to why the biopsies were done. Were they done targeting imaging lesions? Were they done targeting calcification? And is there a difference in the risk associated with that, number one? And number two, was the calcification only found on the microscopy, or was it actually visible as an entity on the imaging? So I'd like to know about different risk there.
Yeah, I think those are great questions. So we did not separate by reason for biopsy. So we have not yet analyzed whether these were, mass targeted, calc targeted, that we just lumped them all together. And so we do believe that that's likely a reason why our results are differing from what was presented this morning. As far as where calcs were seen, because we have not yet analyzed the mammography data and are solely looking at pathology data, there is a possibility that we're identifying calcifications on pathology that were not indicated or identified on radiology. And so that's our next step really is to dig into mammography data. And so I think you've identified exactly our two next steps for the project. Yeah, thank you.
And a third, but perhaps differentiating the different types of calcification, because there are multiple different types, and whether they ascribe a different risk. Thank you.
Yeah.
Thanks for the question. And to that point, I'll just add that Dr. Claudia Fischbach's work at Cornell Ithaca has looked at molecular signatures of the various types of calcifications that you're looking at. And I think it might be fascinating if you have tissue available to stratify risk by molecular signature of the calcification.
My current work is on actually morphologic features of calcifications within these biopsies. So I use micro-CT to get a high-resolution morphologic picture, and so we will characterize them that way as well.
Great. Well, I'm afraid, I know we have some more questions, but I'm afraid we do have to move on to the second half. So I'd like to thank the presenters for joining us this evening, and thank you, Dr. Goodwin, for the excellent discussion. The posters are on display in the back of the room, so please feel free to approach the posters and the speakers at the end of the session. So we'll move to the second half of the evening, and for this second half, we have an additional 4 presenters, and Dr. Khan will conclude with a discussion to summarize the data. So our first presenter is Dr. Letelier, I hope I'm saying that right, from MD Anderson Cancer Center. And he will be presenting a novel citrulline ENO1 peptide-based vaccine for triple-negative breast cancer prevention. Thank you. That's the big green button.
So my name is Ricardo Leon Letelier. So thank you for the invitation. I'm going to talk about what we're going to do in the lab. So it's under the Hanash Lab, Clinical Cancer Prevention. So our lab is very big on proteomics. So the idea is to use this data to figure out a better way to obtain antigens to use it for cancer vaccine development. So we gather up information for the surfaceome, or from the plasma of breast cancer patients, the Ig-bound proteins, and also more important, I would say, is the immunopeptidome. All the MHC-bound peptides, those are the ones going to be actually presented to the T cells. Gather up all the information and did a immunogenic prediction in silico to figure out which are the peptides that could be very good for cancer development. Interestingly, one of the targets that we found was enolase that was already being used previously, but our data says that it has some post-translational modification, especially citrullinatation. And this makes the peptide more foreign, more antigenic, so we put that to a test. At the end was only 3 peptides. We compared them between the citrullinated one against the unmodified one to check changes in immune response, tumor growth, and overall survival in a BRCA-mutated model, a TNBC orthopedic syngeneic model, 3 times a week. So after that, 1 week after the last round of immunization, I want to say that also we use poly-IC for activating some dendritic cells that are known to cross-presenting to the idea to have CD8 and CD4 response. So we can see here that only the citrullinated on yellow can increase the PD-1 positive CD8s on the lymph nodes, and also increasing the effector memory, which is depicted by CD44 positive and CD62L negative. Interestingly, the unmodified one didn't find any change comparing with the PVS on green and on red, the adjuvant alone. The same thing is been seen in the skin. In the immunized skin, we saw only the CIT-INO one has a increased PD-1 CD8 positive, and in CD4 was a little bit different. But those snapshots from the immune characterization explain a little bit what we saw in the tumor growth. So we can see that PVS, the adjuvant alone, and the modified vaccine, the tumor growth was very similar. Comparing with the citrullinated, it was delayed, and we can see also in the survival curve. So this approach of using proteomics, immunopeptidome, surfaceome, all these proteomic data has been able to develop a cancer-selective PTM, post-translational modified citrullinated INO1 peptide, cancer vaccine for TNBC, which stimulates potently the anti-cancer immune response. Interestingly, the unmodified one didn't have any effect. And considering that this has been used on a BRCA mutated, could be also used in high-risk women patients. Thank you very much.
Thank you. Okay, so our next presenter is Dr. Cassandra Moyer from the MD Anderson Cancer Center in Texas, and she'll be presenting the RXR agonist IRX-4204 delays the formation of BRCA1 mutant mammary tumors via modulation of anti-tumor immune response.
Thank you. Okay. So as we have heard already, selective estrogen receptor modulators and aromatase inhibitors can prevent the formation of ER-positive tumors. However, they do not prevent ER-negative tumors. We and others have shown that agonist of the retinoid X receptor can prevent ER-negative tumors in preclinical models. And here I'm showing data from our lab where we started treatment with the RXR agonist IRX-4204 at 3 months of age, can significantly inhibit the formation and even prevent the formation of ER-negative tumors in the MMTV ERB2 mouse model. As we know, familial breast cancer associated with BRCA1 or BRCA2 mutations are more likely to be triple negative. So based on our previous data, we hypothesized that by targeting the RXR pathway, we can prevent the development of triple negative BRCA1 mutant mammary tumors in mice. So we tested this hypothesis with 2 similar experiments. In the BRCA mutant P53 heterozygous mouse model, where female mice will develop tumors at a median age of 200 days. In both experiments, we started treatment at 16 weeks with a low dose or high dose IRX, as well as the RXR agonist UAB30, which is currently being tested in a phase 1 clinical trial of early stage breast cancer. And here we can see in the first experiment with 5 days of treatment each week, all of the RXR agonists significantly delay the formation of tumors with IRX 10 mg per kg having the most delay, where 30% of the mice were still tumor-free at 400 days. In the second experiment, we tested a lower dose of IRX with 1 mg per kg, and as well as only treated 3 days a week. And in this, we still see that the high-dose IRX 10 mg per kg significantly delayed tumor formation by 50 days over vehicle. When we look at tumor biomarkers from the tumors, we can see that IRX as well as UAB30 treatment significantly decreases Ki67 tumor proliferation, as well as IRX decreases cyclin D1 cell cycle marker. And the IRX 10 mg per kg, where we see the greatest effect, also increased cleave caspase 3 apoptosis. In an effort to understand the potential mechanism by which this is happening, we were surprised to find that when we treat the BRCA1 p53 cell lines in vitro with IRX, there is no decrease in cell growth. However, we do see changes that you would expect from an RXR agonist, where we have increased lipid droplet formation, as well as increased expression of SREBF1, which is a key transcription factor involved in lipogenesis as well as glycolysis. Based on this and the fact that others have shown RXR agonist can modulate the tumor microenvironment, we hypothesize that potentially the effect we're seeing in vivo is due to an indirect effect on the tumor microenvironment by IRX. Concordant with this, we actually found that the tumors from our IRX 10 mg per kg mice had increased infiltration of CD8 positive T cells. Because metabolites are known to also stimulate the tumor microenvironment, we are currently looking at whether or not the metabolites we see changes from our RXR agonist can affect the tumor microenvironment in our mice. So based on our current findings, we believe that targeting the RXR pathway should be considered for the prevention of breast cancer in high-risk patients, alone or in combination with other preventative therapies. Thank you.
Okay. Our next speaker is Dr. Erin Giles from the University of Michigan, and I will attempt to pronounce this drug name. She will be presenting basedoxifene plus conjugated estrogen, reduces mammary proliferation markers, and improves adipocyte size, microbiome, and metabolic health. Thank you.
So thank you. I appreciate the opportunity to share this data today. And so many of you heard, especially today, earlier in this session, that one of the biggest problems women who are at high risk for breast cancer may have is being convinced to take tamoxifen for risk reduction. And this is limited basically because of the fact that they have concerns about side effects, including vasomotor symptoms. And in women who are already overweight or have obesity, it is also known that tamoxifen can increase the risk of type 2 diabetes, metabolic syndrome, as well as hepatic steatosis. One possible alternative is an FDA-approved drug called basedoxifene combined with conjugated equine estrogens. And this is approved for treatment of vasomotor symptoms as well as the prevention of osteoporosis. And for those of you who were in the prevention session yesterday, you'll heard that there's many ongoing cancer risk reduction clinical trials with this combination. One of the problems is that we don't know what effect obesity has on the response to this drug, particularly the tissue response at the level of the breast or for these metabolic outcomes. And so given those gaps in the knowledge, the goal of our study was to use a rat model of cancer risk and obesity to address the modifying effects that basedoxifene and conjugated estrogen may have, both on biomarkers of cancer risk in the mammary gland of these animals, as well as metabolic outcomes. I guess I can't go back. Yes, I can. Okay, sorry. So we used this rat model. I'll just highlight a few key aspects there. We used Wistar rats. These are an outbred rat model. That means they're all genetically slightly different. When we place them on the same high-fat diet, some will become obese and some will stay lean. And so we had animals that were obese and lean. We randomized them to treatment at 37 weeks of age, so older animals, which is a little bit different than many preclinical studies. And we're trying to model here sort of the perimenopausal woman who might be considering cancer risk reduction. So they were randomized to basidoxifene with conjugated equine estrogen in the food for 8 weeks, and this was a daily bolus of the drug. And so when we look at the data, we find that there was a significant reduction in both body weight, and here I'm showing total body fat in the obese animals in green and the lean in purple. Specifically, we saw a reduction in visceral fat, and this was predominantly in the obese animals. Further, we saw a reduction in insulin resistance measured by HOMA-IR, so a measure of both glucose and insulin in the plasma. And we saw an increase, which is a metabolically healthy thing, to see an increase in the ratio of adiponectin to leptin. So these are adipokines secreted from the adipose tissue. And this was seen in both the lean and the obese animals. When we looked at the mammary tissue, we did gene set enrichment analysis, and we saw that there was a reduction in both lean and in obese animals in several proliferation-related pathways. And finally, when we looked at the microbiome, we saw that there were beneficial changes in several species. Here I'm highlighting two that we are known in the literature to be associated with improvements in both metabolic health as well as total body fat. And in our study, these correlated nicely with both leptin, circulating leptin levels, as well as body fat. And finally, while I don't have time to show this today, we did a similar study in ovariectomized animals modeling menopausal women, and we saw similar changes. And so in summary, we think that basidoxifene and conjugated equine estrogens is a potential agent that could have beneficial effects for breast cancer risk reduction, particularly in women that might have obesity, as it has been shown to improve metabolic health. And there's early phase 2B clinical study that's going on. There's a poster downstairs right now from Carol Fabian's group showing that we see similar reductions in insulin resistance in women who are taking this same drug. So in summary, I think this is a great alternative potentially as a potential alternative to anti-estrogens and maybe a good agent for use in women with obesity.
Okay, and our final poster presenter for this evening is Dr. Lanning from Haukeland University in Norway, and he'll be presenting prenatal BRCA1 epi mutations as a major cause of triple-negative breast cancer.
Sorry, to go back. Okay. I'd like to thank the organizers for giving us this opportunity to present our results of this study. And just to clarify, when I talk about epimutations, that's synonymous to hypermethylation of the promoter, in this case BRCA1. And what you see on top here is the whole hypothesis of the study, namely where normal tissue epimutations in BRCA1 appear, how they present, and how that potentially influence the risk of triple-negative breast cancer. And the whole thing started with the study we see up on the left. We published in JAMA Oncology last year, where we were able to show that in collaboration with the Women's Health Initiative study, that if you looked into DNA from white blood samples from healthy women, BRCA1 methylation, epimutations, successively predicted elevated risk of triple-negative breast cancer. You can see that on top, and particularly what you see on bottom there, that if you just took the subgroup who had the samples collected more than 5 years prior to diagnosis, it also predicted the risk as well. So that led to the hypothesis we have at the bottom. The question is these epimutations, while we can detect them in blood of healthy women, when do they actually appear? Is this something they develop during adult life? Is this something that happened during prenatal life? In that case, is it inheritable? And most of all, in case we think that this is a kind of clonal evolution of epimutational cells that successively develop into cancers. We need to show that the methylation profile, epimutation profile, is similar in the cancer cell and normal cell. And that can be shown in the way that when you look at the way we did this study with next generation sequencing, you can look at allele-specific methylation, and there is SNP in the BRCA1 promoter. That means that for those patients who are heterogeneous for that SNP, you can also detect exactly on which allele the methylation is located, because what we showed in the previous study was that this methylation is not random. It is localized on the allele of a few cells. It's a low mosaic methylation pattern. And to take you through this, if we start with that marked 3 to 4 at the bottom, what we see there is that, first of all, there is a strong correlation between methylation in white blood cells and tumor when you look at the triple-negative breast cancer. And also when you look at those breast cancers who harbor estrogen receptor expression less than 10%. And we know from gene expression profiles that they are very similar to the triple-negative in gene expression profile. However, in the normal estrogen receptor positive and HER2 positive tumors, there is no correlation between epimutations in the blood and in the tumor. When you look at the figure to the right, what you see in the two columns to the very right is the number of the fraction of triple-negative patients who had germline and somatic BRCA1 mutations. About 5% of triple-negative breast cancers had mutations, either somatic or germline. However, when you look at methylation, the two in blue, about 10% had somatic methylation, and 20% of the tumors had concordant methylation both in the white blood cells and tumor. And when you look to the right, we see that the methylation pattern was similar in newborn girls and adults, but it was twice as frequent in ladies, girls, as compared to men and boys. And the take-home message is that white blood cell methylation is detected in umbilical cord blood, also from girls and boys at birth, indicating a prenatal origin, and also that methylation is twice as frequent in females as in males. And I couldn't go into that in detail, but it was also shown that there was no correlation, it was shown also on one of the tables, between methylation in the newborns and parents. And this constitutional methylation is associated with and likely the underlying cause of about 20% of all triple-negative breast cancer and low-level estrogen receptor breast cancer, but not luminal and HER2 cancers. Thank you very much.
Great, thank you. So for our final speaker this evening, I'd like to invite Dr. Seema Khan from Northwestern University in Illinois to the podium to put this data from the second half together for us. Dr. Khan.
Okay, well, thank you very much, Dr. Iyengar, and good evening, everybody. I'm very pleased to be here to raise some questions about the wonderful data that we've heard this evening, very provocative posters. I'm grateful for the opportunity to do this, and I will try to keep it short. So I've rearranged it a little bit, starting with Professor Loning's work on the triple-negative breast cancer and BRCA1 epi mutations, and then working through the prevention posters to the last one, which is the most developed in terms of clinical data. So this is a story that Dr. Loning's group has been pursuing for some time, with some very nice papers published in the past, and this is a diagram taken from one of their publications just illustrating the difference between somatic mutations, the germline tumor suppressor gene mutation situation, and these mosaic, relatively rare allelic tumor suppressor genes that have been silenced in otherwise normal tissue that can lead to an increased risk for cancer. So we heard a lot of the very strong data that they've put together. The thing that was most compelling to me in terms of showing the association between this methylation pattern that seems to be prenatally acquired and the subsequent risk of cancer is this a relative fraction of 20% almost of TNBC that had matching allele-specific methylation in both the tumor and the WBCs. In tumors that were TNBC or ER low, compared to less than 1% in the over 300 tumors that were not TNBC or ER rich. So this is a very strong association and builds on prior work, also in other tumor types, actually, and with other tumor suppressor genes. But there are some questions related to it, which I will go through quickly here. I don't know if we'll have time to discuss them maybe afterwards. Would be very interesting. But anyway, the things that occurred to me is this an age-specific phenomenon? Because BRCA1 promoter methylation is observed in a greater percentage of women under 40. This has been published previously, also in a study from Australia. And then this also happens in a proportion of the healthy population. And how are we going to sort that out? Because population-based data will be important, but difficult to acquire, perhaps. And then the odds ratios are relatively low. So when you have a rare tumor, triple-negative breast cancer is a rare tumor, and then add a small odds ratio to it, then what will be the clinical value in terms of implementing this information? Dr. Leon's presentation was also very provocative. This is the citrullination is a post-translational modification that is known to be important in generating immunogenic proteins. And so I will skip some of this, but just go to his data and point out that the upper panel is actually data from a prior study from Dr. Hanash's group, showing that these citrullinated proteins are more frequent in triple-negative breast cancer. And then you've already seen the animal data from their study. I would just say that in terms of prevention, this is not a spontaneous tumor prevention model. This is a xenotransplant model where fairly aggressive cell lines were implanted. And so this should really, for a prevention setting, be repeated in a spontaneous tumor formation model. Translational steps I won't go through, we don't have the time, but this has been pretty well defined in several publications. I'll just focus on the last one, which is if one is developing this as a vaccine to prevent triple-negative breast cancer, we can't really recognize a triple-negative breast cancer future patient by the color of their eyes or whatever. So it will be very important to identify the population at need. And also to explore the efficacy of this strategy for prevention of other types of tumors. Do I really just have only 2 minutes remaining?
I'm afraid so.
Oh, all right. Okay, so for the RXR inhibitors, this is also an ongoing search, a campaign that has been very strongly implemented at MD Anderson, actually. So we should be grateful to Dr. Brown and others at MD Anderson and other places to pursue this idea, which has a lot of merit of using RXR agonists for breast cancer prevention. The clinical data are very scant on this particular form, which is a relatively novel agent. And there are only 2 trials that I could find, one which is ongoing with a combination with erlotinib, and the other which was actually presented at ASCO in 2015 and is not yet published. So I wonder about that. But anyway, it's sort of aspirational at this point, but certainly worth pursuing and very exciting. And I congratulate the investigators for looking at the question of dose and frequency. And there is some efficacy still with the reduced dose and lower frequency, but there is some attenuation as well in the effect. And then the lipogenesis story is very interesting too, and the fact that this lipogenesis may be part of the reason that these immune modulation effects are seen. There's a lot of background data to support this investigation into the immune modulation, and I know that this team will pursue those. And then finally, on the bazodoxifene story, I think this is a really nicely done preclinical study looking at both breast cancer prevention effects as well as effects on metabolism. And so you've heard these results very recently. I won't repeat them. They're very consistent and nicely put together. But it was an ovary intact model that was used for the data that we saw, although we heard that similar effects are seen in ovariectomized rats. Now, the version of this poster that I downloaded from the website, the San Antonio website, specifically talked about premenopausal women. So I apologize for this because I noticed that Dr. Giles actually has changed it into menopausal transition. So I think that's more reasonable. And so I'll rest my case about that because she's not intending to apply this to premenopausal women, which will be a different story. So there we are. I think there is progress.
Okay, thank you. Well, thank you very much, Dr. Khan, for getting that in very quickly. I'll take one question. I'm afraid we have to close the session, but we have somebody at the microphone. We'll take one question this evening. Please go ahead.
Hi, I was just wondering for the bazodoxifene plus conjugated estrogen, what the mechanism of action you thought might be playing the biggest role. Is it a synergy between the two, or maybe more the bazodoxifene or more the conjugated estrogen?
Sorry, can you repeat the beginning of that?
Oh yeah, no problem. I was just curious your thoughts on the mechanism of action. Did you think it was more a synergistic effect of the two medications, or more the estrogen, or more the bazodoxifene?
Yeah, so I think that some of the effect is due to a decrease in food intake. So we did see that, we did measure food intake, and we do see that, at least in the obese animals, there's a reduction in food intake, but there's definitely some effects that are beyond that. And so I think we're getting the anti-estrogen effects of the bazodoxifene at the tissue level, whereas I think many of the effects of the conjugated estrogens are what are suppressing food intake and maybe having the metabolic changes. And we may not see those in women. I think that the preliminary data in women may suggest the body composition may not be as good, even though the insulin-resistant effects are just as good. And I was talking with somebody earlier that the rats are nice because they eat everything we ask them to, and they don't go out to dinner with their friends afterwards. So,
thank you so much.
Great, thanks for the question. I was similarly going to ask, is it really the conjugated estrogen that's driving the positive metabolic effects? I would almost anticipate that the bazodoxifene alone might actually worsen. I would almost anticipate that the bazodoxifene alone might actually worsen the metabolic effects. What do you think about that?
I think other studies in rodent models have shown that bazodoxifene on its own does have beneficial effects. We didn't separate the two in this study, so unfortunately we can't speak to that. But I think, yeah, it's a combination.
Okay, great, thank you. Well, I'm afraid I have to close the session. We are at the hour, but if you have questions for the speakers, please approach them either here or at the posters in the back. Thank you very much for joining us this evening.